Welcome to Thinking Ahead, Scheduling Your Clinical Year. I'm sure you have a lot of questions and anxieties about the upcoming clinical year, and hopefully this presentation will help you understand what goes into scheduling and what you can expect. We know you've only been in PA school since May, but it is time to start thinking about clinical rotations. This is an exciting and anxious process, so we want to cover a few topics that will help you better understand the process and know what to expect over the next several months. I'm sure you have heard us refer to ourselves often as the clinical team, but likely there are some questions about who does what and how we ultimately all work with you. This information will also help you reach out to the best person for your needs. When reaching out to a member of the clinical team, it's not a bad idea to CC everyone or one or two people you think who are the best fit. We are all juggling a lot, and often one of us doesn't have the answer you need, and we want to respond as quickly and accurately as possible. It's kind of like how the CEO might be able to help you order new tissues for your office, but other people fit that responsibility better and faster. Marie is the Associate Clinical Education Coordinator. She is essentially the PA representative on the team, guiding the rest of us who are not clinicians. She is primarily responsible for student site visits and can answer any questions related to medicine and being a PA. Summer is a clinical education coordinator. She is the paperwork master, which means she ensures every one of you is in compliance with site requirements, so you can have the privileges you need to participate in clinic. She is the go-to person about exat, especially with your student profile. Jennifer is the clinical coordinator. She is the primary scheduler. So if you have questions about referrals, scheduling, or your preceptor evaluations, she is usually the one who knows what is going on. And Amber is the director of clinical education. I can help you on a broad scale with most of these things, but I don't always have the specific details other members of the team have. It is most appropriate to reach out to me for overall management topics, major concerns and issues, and the academic and grading side of rotations. But again, when in doubt, just copy all of us. We don't mind, and it really does help you get the fastest response possible. It is important to review some clinical education terms to make sure you understand all of the acronyms and things we're talking about. You'll be starting your clinical year next fall. We call the sum of your entire clinical experiences SCIPEs, or Supervised Clinical Practice Experiences. SCIPEs encompass the learning outcomes you are required to complete across the entire clinical year. Rotations are part of the SCIPE experience. A rotation is just one way to accomplish your SCIPEs and is basically just a formal set number of weeks set aside to complete SCIPEs in one particular area. It is important to recognize that when we think broadly about the clinical year as SCIPEs, instead of focusing on rotations, it gives more flexibility for students to accomplish their clinical learning outcomes. For example, you don't have to be in a pediatric rotation to see a pediatric patient. Let's say you treat a 15-year-old with a broken bone. That experience can count as both emergency medicine and pediatrics. What if you see a woman in your women's health rotation with postpartum depression? Couldn't that also count as a behavioral health encounter? Perhaps you encounter a teenager during your pediatric rotation with severe menstrual cramps. That's peds and women's health. And maybe you encounter an epileptic seizure during a behavioral med encounter. Perhaps that might count as emergent or chronic care. Focusing on SCIPE outcomes rather than just rotations has helped our program advance learning and patient care abilities of students. It has also been the vehicle for which students have been able to graduate on time, as many students did meet all required outcomes for graduation, even while missing formal rotation hours and weeks because of COVID. Next, let's review an ARC-PA accreditation standard that guides this entire process. A3.03. The program must define, publish, make readily available, and consistently apply a policy for prospective and enrolled students that they must not be required to provide or solicit clinical sites or preceptors. So what does this mean in layperson's terms? Basically that we do not allow students to schedule their own clinical rotations. So let's check out some clarifications from the ARC. Coordinating clinical practice experiences involving identifying, contacting, and evaluating sites and preceptors for suitability as a required or elective rotation experience. And students' suggested sites and preceptors are to be reviewed, evaluated, and approved for educational suitability by the program. So basically, referrals for potential preceptors are accepted and appreciated, especially if you have a specific area that you want to be in that's outside of Utah. Keep in mind, giving a referral does not mean you are guaranteed that placement. It does not guarantee it will fit the needs or requirements for you or the program. And just because a preceptor seems open-minded to hosting a student does not mean they can provide the education opportunity you actually need. And it also does not guarantee that their administrators are open-minded. And it also doesn't guarantee that contracts are always available. And I especially want to emphasize something that students often misunderstand, that making a referral does not even come close to qualifying as scheduling a rotation. As you can see from the ARC-PA, there's a lot more to scheduling, or coordinating rather, a rotation than just giving a suggestion or referral. So what's the difference between a suggestion, a request, and a referral, at least according to our team? When we start scheduling rotations, we start with referrals. Referrals are defined as the student provides information for a specific preceptor who is not already associated with the school. Thus, referrals require specific information and details about preceptors and are submitted through our online system. In contrast, requests are when the student asks for a specific site or preceptor who is already associated with the school's clinical sites. After we reach out to referrals, we contact our existing relationships to see what they're willing to do. Students may certainly submit a request to do a rotation with the provider we already have in place, but again, there are no guarantees we can honor requests. For example, you might really like a provider who maybe does a guest presentation, and you would like to do a rotation with that person because they do regularly take our students. But again, we may or may not be able to make that work for you. And last, we sometimes, probably more rarely, consider suggestions, which is when the student asks for a specific site or a preceptor who is not currently associated with the school, and the student does not have a specific contact with that possible preceptor. Basically, suggestions are pretty much cold calls because the student is saying, hey, I drove past a cool clinic the other day, I'd like to go there, for example, which means the team has to start from scratch. These are the least likely to work out and yet the most time-consuming rotations to schedule. Often cold calling requires dozens, if not hundreds, of phone calls just to acquire one placement. With that accreditation standard in mind, it is important that we are all on the same page about how we talk about referrals and scheduling rotations. Students who are familiar with these policies have even made the mistake of talking about this incorrectly. For example, in a discussion I had with one student, the student said at least 5 times that he secured 6 rotations himself. Let's think about that. Why is that a problem? What can happen as a result of this type of language? What would happen if someone from the ARC-PA hears a student saying that? What could happen if other schools or students from other schools hear you say that? One example is we had multiple applicants one year ask us about this because another PA school told them that we required our students to fill their own rotations, which again is incorrect. Another time, a preceptor told us that he didn't think students should be required to spend so much time trying to schedule their own rotations. Again, this is a misunderstanding. Let's think about what implications can arise from this, the impact on the program, impact on interviewees trying to get into the program, our relationship with preceptors, what happens with the ARC-PA, etc. And keep in mind, in most cases, providers don't want you scheduling. It's overwhelming to them, and they'll often say, well, how many people are going to be asking me about this? So why is this so important? Violating accreditation standards and policies have the potential to damage relationships, put the program at risk, and hurt potential clinical opportunities. And it can also cause you, as a student, to be put on professionalism probation or worse. Unfortunately, the program has seen complications from students scheduling or coming pretty darn close to scheduling their own rotations, both blatantly and simply by just not thinking things through. Let's give a few examples that you can learn from. Example number 1. One day our team reached out to a site to inquire about potential rotations. They said they wouldn't be able to take any more students that year. Within the next 2 hours, one of our students called the exact same person asking if she could take him. What do you think are the implications of this type of behavior? What will the sites think about how Rocky Mountain University operates? This example reminds me of when kids get an answer they don't want from one of their parents, so they send in the younger, cuter sibling to ask, hoping to get another answer. We definitely do not want sites to think we can't respect their wishes, or that we are trying to manipulate them by sicking our students on them to try to get a different answer. Example number 2. One day we were copied on an email a student sent to a provider, featured here. Hello, Dr. So-and-so. I appreciate you being willing to take me on for this rotation. This hospital is so close to home, it'll be nice to be able to be in town with my family for my rotation. I have copied the directors of clinical rotations for Rocky Mountain University. They will be able to answer any questions that you may have concerning paperwork and processes necessary to set up this rotation. I look forward to learning a lot from you. Thank you again. What are your observations about this email? How is this different than making a referral? So the biggest problem here is that the student made the rotation sound like a done deal. What could be the implications of doing this? In this particular case, we had already scheduled the student for this exact rotation with another one of his own referrals. To make it worse, the student told a couple classmates about the old spot and that they could have it. Interesting enough, in the end, the referral couldn't even take him due to administrative issues. Also keep in mind, referrals often are doing a special favor specifically for the student that they know. So simply giving your spot to someone else rarely works out. Here's another example. Later in the year, we will ask you to stop reaching out to providers after a set day, as doing so starts to muddy things up for the clinical team. Let's look at another email from a student. Clinical team, I've been reaching out to get so-and-so a local pediatrics rotation since their family situation's changed. This doctor, who works in the same office as another doctor that I rotated with, is willing to take her for that rotation. I did a couple of shifts with him, and he is a fantastic preceptor. His office manager's name is blank. The contact information is listed below, so you can get the ball rolling. Thank you. So why would we mind an email like this? Isn't it nice? Well, the problem is this particular preceptor already told us how many students he wanted to precept. This email is a contradiction to that. When we reached out again to clarify with the preceptor, he said he'd really prefer to stick with the original agreement and the dates he had given us. Again, what do you think could be the impact of this type of interaction with this preceptor? And here's an example of someone who didn't like his or her placement. And here's an example of a student who just didn't like their placement. So they set off to find their own replacement site. To make things worse, this student asked a preceptor we were already sending multiple students to, and didn't want to take any additional students. We were also needing a strong student to send to the new site, as it was a site we'd been working on developing and needed a strong relationship on. The point here is there are a lot of factors to consider during scheduling besides just finding someone who's willing to precept. In addition to not harassing our existing preceptors to take additional students beyond our initial agreement, preceptors and their administrators put a lot of time, which again equals money, into getting rotations set up. Simply canceling one just because a student does not want to travel does not help relationships with our valued partners. Let's look at another example. One day I got a phone call from a student asking if they were set to go for their rotation next week. I didn't know anything about the arrangements that had been made because I wasn't the one scheduling it. But because the student was talking about a preceptor we already worked with regularly, and the student said the preceptor had agreed they could come, I said it sounded like it was probably a go. I was confused because I had heard the site had pulled all their students due to COVID, but I told the student I would check in with my team just to double check. Turns out this student had spent weeks making arrangements with this preceptor who thought it was approved by the school. Meanwhile, the clinical team had absolutely no idea what was going on. Turns out this preceptor was making a special exception for this particular student as a personal favor. But not only was this a major violation of ARC standards, but the student would have actually displaced a peer who had been scheduled at that site and needed the experience more. So what are the takeaways? Clinical rotations are very complicated, and the impact of overstepping your role can have major impact on you, the program, our preceptors, the the university, and ultimately patients. The point is for you to be thoughtful and careful about following the policies. Some of the complications that happen when a student breaks policies include fruitless work of the clinical team, which means less attention to other details, negative impacts on relationships with sites, limited opportunities for future students, interfering with already scheduled rotations, and potentially much more. So let's shift gears and introduce you to what actually goes into the scheduling process. It can be a very complicated process with a lot of people to talk to, a lot of correspondence and paperwork to keep track of, and several legal and accreditation requirements to maintain compliance with. We are here to make your clinical experiences as positive as possible. As a team, we truly try to approach scheduling with the mindset of treating you the way we would want to be treated. And that sometimes means prioritizing decisions in a way that you may not always see or recognize or understand. For example, we would rather send you somewhere quality than somewhere convenient, just like we would rather you graduate on time than stay near home and graduate later. We do evaluate student needs, the needs of the preceptors, and the needs of the program and the university, as well as accreditation and graduation requirements. We do want you to understand that there's a lot that goes into scheduling of rotations. And simply asking for a particular rotation or referral doesn't mean that things will work out. There are a lot of elements that are outside of our control. But what's up next for you? What can you expect? In January, the clinical team will start to devote attention to your cohort and begin the process of scheduling rotations for your clinical year, which begins in September. If you have referrals you would like to use, start having conversations with family and friends about the possibilities and collecting the appropriate information. Remember, you are not scheduling your own rotations. You are simply providing warm leads of people that are willing to help you. Ask for help. Don't make any promises. Don't give them any times or dates. If they say yes, collect some basic information we need and let them know that your program will reach out to coordinate any appropriate details. This is a script that might be helpful for you as a guide. Something like, I will start my PA clinical rotations next September. I wondered if you might be willing to serve as a clinical preceptor for me. Yes? Well, that's great. Can I get some basic information? And then I'll have our clinical team reach out to you within the next couple of months to make the arrangements. There are several pieces of information we need for each referral. Name, email, phone number, specialty and position, their clinical site with the address, what's the name and contact information for the scheduling coordinator, who's often a different person than the preceptor. Is there a different person for the affiliation agreement contact? Sometimes it's the same person as the others. How do you know this preceptor? Basically, are they going to know who you are when we reach out? Do we need to use a relative's name instead? And is there anything else that will be helpful for us to know as we proceed with your referral? Our team uses a system called CODA to manage the referrals you submit to us. It is a software system. Kind of looks like a website but runs similar to a Google Sheet. It allows you to submit your referrals to the clinical team and then we can update the site to show you your referral status. That way if things don't work out, you don't have to wonder if we never even tried to contact someone, or maybe just did the schedules not line up, did their administrators say no, or maybe the contract didn't go through. And when things do fall into place, you can see the progress that is being made on your lead. We will send you a link in early January containing the CODA referral link. Log in with your student Gmail account and follow instructions on the homepage, and feel free to email Summer if you have any questions. Starting in January, the clinical team will begin meeting individually with each student. This will be to learn more about your unique needs and circumstances that can help guide our placement decisions. Maybe you're having a baby, or you have family you could stay with in Vermont. Perhaps you plan to live in an RV and are hoping for an adventure traveling across the country. Maybe your partner has a serious illness. Or it could be as simple as you're just really nervous about surgery and hope that it comes later in the year. Maybe you're open-minded to Spanish-speaking clinics because you speak the language fluently. There are several factors you may want to include in our discussion. We won't be making any promises or guarantees based on your preferences and background, but knowing some background can help make a big difference in finding the best fit for each student. And remember, we expect that once you have a placement, you will accept that placement. A saying we use around here regularly is, you get what you get and you don't throw a fit. Within a few months, we'll have you create an account and profile on our clinical management system Exact. This is where all of the clinical year details will be managed. Exact is updating its format and software, and we will transition to a new version in a few months. Because of this transition, we will wait and have you join then. We are really looking forward to your clinical year, and it will be here faster than you realize. We know you'll have a lot of questions and some anxiety throughout this process. Please feel free to reach out anytime with questions or concerns. We look forward to working together as a team with you for this exciting journey.